Capsulolabral adhesions are a common cause of revision hip arthroscopy. In this technique video, we will demonstrate the association of labral pathology with the presence of capsulolabral adhesions. Additionally, we will share our technique to adequately resect adhesions and successfully reestablish the capsulolabral interval, which will allow for labral refixation and appropriate excursion of the capsular tissue for repair and/or reconstruction. Notably, the presenting patient was an elite athlete who previously underwent hip arthroscopy for a labral tear and presented with recurrent hip pain. After establishment of anterolateral and mid-anterior portals, diagnostic arthroscopy of the hip was performed. Here, we identified the presence of an adhesion between the labrum and capsule, a capsulolabral adhesion, at the 9 o'clock position. Using an arthroscopic probe, tension was placed on the capsulolabral adhesion, resulting in displacement of the labrum from the acetabulum. Here, we can appreciate the presence of recurrent labral tearing as a result of the capsulolabral adhesion. It is important to note that the patient's prior labral tear was identified and repaired from the 11 o'clock to 3 o'clock position, such that this new tear was in a unique position, directly corresponding to the location of the adhesion. Next, a radiofrequency probe was inserted into the hip joint and utilized to separate the capsule from the labrum. It is important to accurately identify and develop the capsulolabral interval to ensure adequate removal of the adhesion. This allows for 1. Labral refixation when indicated, and 2. Appropriate capsular excursion for subsequent repair or reconstruction without damaging the nearby native labral tissue. Dissection of the capsulolabral interval was continued from the 9 o'clock to 1 o'clock position until complete reestablishment of the interval was achieved. Next, our attention was turned to the 1 o'clock position where a capsulolabral adhesion had formed at the site of the patient's previous labral tear repair. In a similar fashion, a radiofrequency probe was carefully inserted into the hip joint and used to reestablish the capsulolabral interval indicated by the orange arrows. Dissection of the capsulolabral interval was meticulously continued more medially and laterally until reestablishment of the interval was achieved. Additionally, frayed labral tissue was debrided. Here, we can appreciate adequate reestablishment of the capsulolabral interval following complete lysis of adhesions. After reestablishing the capsulolabral interval, labral refixation can be performed in accordance with the surgeon's preference. Thank you for watching our technique video, and we hope it is beneficial for your practice.